Okay. Anyway, can y'all see the slide again?
Yeah.
Okay, sorry about that. I wasn't recording the first couple slides, but I just remembered. So we haven't gotten very far yet. Spinal stenosis, people can develop that over time. They can be born with spinal stenosis, and it just not be a problem until they get older, and then they develop degenerative joint disease, and then it can close in on their spinal cord, and that can be that narrowing. People can have a thrombosis, a clot, or an embolus that forms and travels to their spinal cord and causes basically like a stroke on their spinal cord. I mean, a clot that travels through an artery. The whole spinal cord's got to get blood, so it's got arteries and capillaries going to it. So if a clot travels to one of those arteries or capillaries and then it gets stuck, well, blood flow is going to get impaired. So it's going to cause some damage. So it can cause like a vascular accident. Arteries on the spinal cord can have aneurysms where they're like weakening of the arterial wall, and then they balloon out until they burst. Remember when we talked about arterial venous malformations, AVMs in the brain? You can have AVMs on the spinal cord too. Now they're going to be much smaller, obviously, because it's a much smaller area, but we can have those. So a lot of things that can happen. Don't mean to scare you, but it is a lot of things. There are different mechanisms of injury. You can have flexion injuries. This is the most common type of injury. This is usually due to head-on collisions or a blow to the back of the head. You have compression injuries, which you would think like something landing on top of the head and causing like a compression type, like fracturing of the vertebrae. Hyperextension injuries, usually this is rear end collisions. And when if somebody falls and their chin strikes an object. So say like if somebody fell and their chin hit a table on the way down, or their chin hit the curb or the sidewalk, or hit something on their way down, that would cause a hyperextension injury. And there's flexion rotation injuries where you're what it sounds like you're flexed and rotated, and it's just a posterior it's a PA force on a rotated column. But flexion injuries are the most common types of injuries, but all of these we're going to talk about a little bit. I've already mentioned this, and you probably already aware of this. Tetraplegia or quadriplegia, it means there's some paralysis of all four extremities. So including, it's maybe the respiratory muscles too. They can or cannot be included, but maybe. But tetraplegia is always going to be a lesion to the cervical cord segments, always, every time. Now, there's different levels of tetraplegia. There's people that can't move anything in their tetraplegia, and there's people that can push themselves around in a manual wheelchair and go to work and drive every day and still have upper extremity loss, and they're quadri or tetraplegic too, but it's because of where they were hurt. We're going to get there. Paraplegia is paralysis of just part of all or part of the trunk and both lower extremities. So automatically both lower extremities, but the trunk can be included in this too. This is just a quick visual view of the spinal nerves coming off the spinal cord. And if you remember, we have 7 cervical vertebrae, but we have 8 cervical nerves. So remember that the cervical spinal nerves come over the top. They exit the vertebral column on top of the vertebrae, and then all the thoracic, lumbar, and sacral the spinal nerves come out from the bottom of the vertebrae. So that's how we have an extracervical nerve. The top of mine is covered up by the top of my Zoom box, but if you can't see that on your screen, if it's covering up yours too, this if you see the link down here, this link is still active and you can see the picture, or you can look in your A&P book or even big red and you can see more. Now, just while we're on this picture, I do want to say there's a document in this week's lecture folder, and I think it's entitled Spinal Levels and Function. It would be a good idea. I'll let you know. We'll do it after break, but after we take our first break, it'll be a good idea to get that document out. And if you're at home, if you have a printer, print it. If you can't print it, just maybe have it like minimized to on the side of your screen so you could follow along whenever I'm going through it. We're gonna, as we talk about every kind of spinal cord injury, we'll go through what different types of what each level would allow a person to do. So we'll go through like what a C1 injury would be able to have left as far as motor function, what a C2 would have, what a C3 person would have, and all the way down the list. It's not as long as it sounds like, I promise, and it's not that complicated, but it is a pretty big chart. And so, you know, you had to memorize those myotomes and dermatomes back with Miss King and A&P. Well, now they're going to come back and haunt you, especially the myotomes. So if you don't remember those, get out your old A&P stuff, and you'll have it there for you there. But I've also got some stuff written up for you too. Okay, so let's talk about discussing a spinal cord injury level. So there's a lot of different terminology when it comes to what a person's injury level is, okay? Well, let's define those. So when a person says that when people talk in the spinal cord world talk about what their injury is, or they talk to other people, they say, yeah, I'm a C6 quad, or I'm a T1 para, or I'm a T6. Yeah, that's what that means. Well, what do they really mean with that when they say that? Well, when they say that level, they're saying that's their neurological level. That's the most caudal level of the spinal cord with normal motor and normal sensory function still preserved bilaterally. So remember, caudal means tail. So it's going to be the lowest level down on of the vertebral column, where the spinal nerves, when you test their myotomes and dermatomes, which we'll talk about testing later, has normal motor strength and normal sensory function bilaterally. That's called the neurological level. Okay, so when they say I'm a T1 para, they mean, what they're saying is that all of their cervical vertebrae and spinal nerves are still intact, and T1 vertebrae, T1 myotomes and dermatomes are the lowest level that's intact. T2 dermatomes and myotomes are impaired. Okay, and then you can even separate it down and make it even more confusing. You can have a motor level and a sensory level. Okay, so some people are going to have motor levels that stop at one level of the spinal cord and sensory that keeps going down to another level. Or it could be the opposite. They could have motor that goes down to a certain level and then sensory that's preserved up, but not quite down that far on their body. So a motor level is the most caudal segment of the spinal cord with normal motor function bilaterally, okay? So we do use the standard MMT 0 to 5 scale, but it is a little, the testing positions for spinal cord patients are like 100% different than what for everybody else, what you learn at Kines. So don't even think you could do the same thing, testing positions for them. I'll show you in lab real quick. You wouldn't be doing it because it would just be part of the eval. But it is really interesting. But the whole thing is done in supine for the upper extremities and the lower extremities, and you only do a few muscles. But they would test your muscles, and it would be the lowest, your motor level would be your most caudal segment, where you have normal strength of 3 out of 5 or better bilaterally. So it's 3 out of 5 or better bilaterally. Sensory level is your most caudal segment of spinal cord with normal sensory function bilaterally. And we test that with light touch, like with a cotton swab or with a Q-tip, and then with pinprick testing, like with sharp and dull. So we usually don't do hot, we do hot and cold like we would do in PTA techniques, but for spinal cord levels, for standard testing, they do light touch with a cotton swab, and then they do sharp and dull with like with a sharp and dull object, or like with a safety pin. And they measure it 0 through 2. So 0 would be no sensation, completely absent. 1 would be if it's there, they can feel it, but it's not normal. They can tell that something's different about it. And 2 would be like it's completely normal. It's what it felt like before. So that's what their sensory level would be like. So a person could have a sensory level of C6 and say they only feel down to the C6 dermatomes, but they could be motor level, they could be a C7, where they have triceps, and triceps are innervated by C7. So they could have triceps, but they're not going to feel anything along that dermatome. So they can extend their elbow, but they almost have to look at it to be able to know what they're doing. They don't have the proprioception or the position sense to know what their elbow is doing. It's real strange. They have to train themselves on knowing how to use their body without knowing where their body is all the time. Okay. So am I losing anybody so far? Still with me?
Yep.
Okay. Okay. So designation of the lesion level. The classification that we use in the United States, and there's different classifications in different countries, but other countries are starting to adopt our scale and modifying it to their scale. But it's called the Asia scale, and it stands for the American Spinal Injury Association scale. The Asia scale is the way we determine a patient's spinal level. And before we move on, I want to show you what that looks like. So give me 1 second. I'm going to show you the Asia form. I think it's the last slide on this PowerPoint. Yep. Okay, so this is the Asia form. If you can't, is the top on the screen getting cut off? Well, this is the Asia form. It's a standard form, and this is what every place in the United States uses to determine a person's motor level, sensory level, and then their overall neurological level. So before you look at the motor section, look over here at the sensory section. You can see that you test all the dermatomes bilaterally, all the way from C2 all the way down to S4 and S5. And if you don't remember, the S3, 4, and 5 reactions are for our anal sphincter, and that should be we should have voluntary contraction there, and we should have a reflex contraction there. Well, remember that's going to be important in just a minute when I start talking a little bit more. They do have to test that reflex. A doctor usually does that. An OT will usually test all of the sensation, and they do it bilaterally with a sharpened dull and with light touch, or I mean with soft touch, like a cotton swab. The motor exam is usually done by the PT or sometimes the doctor, and the OT can do it also if they have time, and it just depends on how you split all this stuff up. Now you can see that there's a box on right and left that goes from C2 all the way down to S4 and 5, but if you look really closely, I know this is smaller on y'all's screen, but if you look at it on your full PowerPoint, you can see it full size. There's certain boxes that are darker than others. Those are key muscles. And you can see up at the top, it says motor key muscles. So when somebody has a spinal cord injury, those are the only muscles that they test to determine their neurological level. Okay. The main reason that they do that is because, well, look, C5, C6, C7, and C8 are really all of your upper extremity and shoulder movements, some of C4. So that pretty much covers all of your cervical dermatomes and myotomes. Well, and then look at the thoracic level. You do test T1 myotome, the finger abductors on the little finger, but you don't test anything else down to L2. Well, all of those other myotomes are for your abdominal muscles and your intercostals and things like that. So we don't test any of those. And really, it's kind of hard. It's hard to test those on anybody in the first place, especially somebody that has a spinal cord injury. We're not going to do that because they're probably not going to be able to do it anyway. And then it picks up again at L2. You test their hip flexors, their knee extensors, their dorsiflexors, their big toe extensors, and then their plantar flexors. And then you can see the scale there. It goes 0 through 5. And then there's no pluses and minuses. So you either get the whole score or you get downgraded to the next level. And then they give you, you add it all up, and then they give you a max score. But you don't really have to know the max score to be able to determine the patient's level. You can look at the chart and determine that. Okay, so now let me stop sharing again. Sorry. Get back to where we were. Don't know why that's out of place. Here we go. So that's how you do the ASIA scoring. And people can change ASIA levels, as I'll tell you later on, as they get better and better, and as they heal. Okay, so different injury types. So some people have what we call a complete injury or a complete lesion. This means that it doesn't matter what level they were hurt at. That all this means is it doesn't matter what their lowest sensory or motor level is, but that they don't have any sensory or motor function in the S4 and S5 myotome and dermatome. Now that's the anal sphincter sensation and the anal sphincter reflex control. That would mean that if a person has a complete injury, that reflex and sensation is absent. Now the physician will be the one that's going to make that call. Almost always. Sometimes it'll be the OT, but usually it does have to be the physician that makes that call. Now, an incomplete lesion is anything else. So it can be where some motor or sensory is preserved below the neurological level, and you have some, if not all, intact S4 and S5 sensory and motor. And we call that sacral sparing. Okay, so that means that you had a really bad traumatic injury, but your S4 and S5 nerves were spared. So that means that you still have your reflex, you still have your sensation, so you're an incomplete lesion. So that means that you're going to have a much, much, much better chance at recovery because you're going to have bladder and you're going to have much better bladder and bowel control. So people are usually going to be complete or incomplete. Okay, complete, the only thing that complete means, don't think of complete as in the whole spinal cord was severed completely. That actually almost never happens where the spinal cord is actually cut in half. That does happen, but that's actually very rare. So don't think that a complete lesion means that's what that means. Complete only means is only talking about S4 and S5 being gone. Okay. Now, you can have what's called, to confuse you even more, what's called a zone of partial preservation. Now, these are people that have a complete lesion and and I'm going to read this bullet backwards. They have no sensory or motor function at S4 and S5, but they still have some motor and or sensory function below their neurological level of injury. So these people do have a complete injury, but they have a little bit things left over below their injury level that shouldn't be there. Okay, that's zone or partial preservation. So let me tell you this. Let's talk about them in terms of severity. If you're going to have a spinal cord injury, if you have to have one, you want it to be incomplete. And then the next would be zone or partial preservation. At least you've got something left below your level of injury that you can use. And then complete would be the most severe. Now you can be a complete or incomplete lesion on any level up and down the whole column, okay? Remember, it just means if S4 and S5 was affected. So don't let that confuse you, okay? Now, this is going a little bit off of topic, but these are, and I probably don't have to tell you this now, as at this point in the semester, but this is a little chart, a handy little chart that I think it may have been in the TBI lecture, or it may be coming up again in another lecture, I can't remember. This is just a good little chart to let you remember what upper motor neuron lesions and lower motor neuron lesions, some of the signs and symptoms. The one thing I want you to remember here is that every single type of spinal cord injury except one is an upper motor neuron lesion. So all spinal cord injuries are upper motor neuron lesions except what we call cauda equina injuries, and those are lower motor neuron. We'll talk about those later when we get to it. And we're going to take a break soon, guys, I promise. Okay, just to review a little bit before we go into different types of injuries. So if this is a picture, this is a cross section of the spinal cord, and the anterior is on the bottom of the screen, and the back of the back of the neck would be up at the top. So you've got your ascending columns going up the back. So that would be all your sensory, your deep touch, your light touch, your proprioception, kinesthesia, those things. And then some of that coming in from the front too, but mostly in the back. And then you've got your motor, your voluntary descending tracts going down the front of your cord, and some going down the side. Okay, so remember this for the next few slides. Just another one. Another one. Okay, so let's go through these really quickly, and I won't spend a lot of time on them. And then we'll take a good 10-minute break after this, okay? because this is a deep lecture today. So these are different types of, when this says Asia impairment scale and clinical syndromes, when it says syndrome, that doesn't mean like an illness. That just means it's a pattern of impairment that follows that type of cord injury. So like Brown-Séquard syndromes have a certain injury pattern, and they show certain impairments. Anterior cord syndromes have certain patterns. It's not like a syndrome, like an illness you catch. It's just a pattern of weakness and sensory loss. So let's talk about Brown-Séquard. This is probably the weirdest one. So we'll start with this one first. This is usually due to a hemisection of the cord. A lot of times from like a gunshot, or like a gunshot wound to the neck, or like a stabbing to the neck, where like say like half of the cord is has been severed. Okay, well, you've had some of those neurons from the brain have crossed already. Well, some of them have not crossed already. Okay, wherever that injury happened, where that hemisection happened. So on the same if you have a Brown-Séquard syndrome lesion, say it happened in my neck, on the same side of my injury that it happened, so on ipsilateral, that's what it means, same side, I'm going to have loss of motor function and loss of proprioception, of joint position sense. And I'll have clonus, and my Babinski reflex will come back. Remember that infant reflex, that will come back. But I will still have my sensation on that side. Now, on the other side of my body, the opposite side of my injury, contralateral, I will lose pain and temperature sensation. But I will keep most of my motor function. It's really, really weird. These are more and more common. These are common syndromes, and there are varying degrees of this. It can occur with spinal tumors and anything that compresses mostly the lateral side of the cord. But it is Brown-Séquard is a really strange one. So I just remember that this is also, Brown-Séquard also means lateral cord syndrome. And Brown-Séquard to me is a weird name. So I think of it as weird name, weird impairment. So it's loss of motor function and proprioception on one side of the body, and loss of pain and temperature on the other side of the body. It's a weird combination of sensory loss and motor loss. And that's exactly what it would look like. So you can see, if you can look at the tracks that are, you can see some of your dorsal columns were gotten, and then some of your spinothalamic columns were gotten too. So you have motor and some of your temperature and pain were gotten to. Just another example of Brown-Séquard, just another look at it. Okay, anterior cord syndrome. Let me get a drink real quick. Okay, so anterior cord syndrome is bilateral, and anterior cord syndrome is where the front of the neck is compressed. Okay, so this is where most of your descending fibers are going to be damaged. So this is typically seen in hyperflexion injuries of the neck. So like if somebody was hit from behind, and then, or they're hit and then their neck gets thrown forward really, really hard, like in an accident, this will compress the front of the vertebrae, will go forward. The spinal canal will narrow, and that will compress the front of the spinal cord. You'll have bilateral loss of motor function, bilateral loss of pain and temperature below the level of your lesion. But because the back of the cord was not really affected, your position sense and some of your sensation is going to be preserved. So you'll be able to feel your legs and your arms and what you lost, but you'll lose motor function, but you'll still be able to feel. Okay. So all this section of the spinal cord here, everything that's darkened on the black and white picture would be the anterior cord injury. And you can see that the posterior columns, or the dorsal columns, where most of our ascending tracts are coming, that's pretty much preserved. So we're going to be able to feel things, and we'll know where our body is in space, but our motor tracts are mostly damaged bilaterally, and our sensory tract, some of our sensory tracts. Okay, central cord syndrome, very, very common, very common injury. Central cord syndrome is most often associated with hyperextension injuries of the cervical spine, okay, or elderly patients that have like spondylosis or narrow cervical canal, and if they get a forward head and their forward, excuse me, their forward head posture gets worse over time, it can make the canal narrower, and it can cause a central cord syndrome. So usually central cord syndromes are going to be associated with, it can be with hyperextension injuries of the neck, or slowly over time with narrowing of the canal due to like osteophytes or degenerative changes, or with postural changes. So when the central cord, when you have a hyperextension injury or whatever is causing this puts pressure around the whole entire spinal cord. So like if my hand right here, if my hand was the spinal canal, it's shrinking, okay, and it's narrowing, and it's going to squeeze the whole spinal cord. So think of it like a water hose. The whole thing is getting squeezed, okay? So not just the outside, but the middle is getting squeezed. Well, the most of the compressive forces on these injuries of a hyperextension are on the middle of the cord, okay? The outside of the cord will be less damaged than the middle of the cord. Well, most of the tracts, the descending tracts for your upper extremities, are in the middle of your cord, of your spinal cord. And most of your descending tracts for your legs are in the lateral part of your cord. So you can pretty much draw the rule that central cord syndromes always have more upper extremity involvement than lower extremity involvement. Now, I'm not saying that they're not going to have lower extremity involvement. They will, or they probably will, but they're going to get their lower extremity strength and sensation is going to come back whole lot quicker than their upper extremities. These people are going to commonly walk, and they'll be ambulatory, maybe without a device, way before they even have anything in their arms. So they may be completely floppy in their arms, but they can walk after a couple of weeks of therapy. I've seen it several times. It is a little weird. Sometimes they are able to walk with a walker, and their legs are just fine and walk nice and fast after a few months of rehab, but their arms are real weak and their arms are really, really slow. And they have a lot of spasticity in their arms. Sensory impairment is variable, just depending on the size and the location of the lesion. Pain and temperature loss is variable. So is proprioception loss. Bladder dysfunction and bowel dysfunction is variable too. But motor loss is more than sensory loss. So just remember, central cord syndromes, more upper extremity involvement than lower extremities, and it's more motor loss than sensory loss. Make sense? Okay. Now, let me skip this and we'll come back to that slide. Now, if this was a cross section of the cord that was having a central cord injury, you can see the middle part of the cord is what's being compressed, and that's where most of our upper extremity tracts are. Now, if somebody was getting just a slow and chronic progressive, like say central cord syndrome from like from a forward head or narrowing of their canal or posture or whatever, they would start having more paresthesias in their hands and in their feet before in weakness. And this would be over the course of a few weeks to few days, to few weeks. That would be an emergency and needs to be taken care of by surgery really, really fast. So if they start having the signs, that's a lot better. They need to get that taken care of before they have an injury, and then they're permanently disabled. More on central cord. Posterior cord syndrome. This one's kind of rare. This one gets mostly your kinesthesia and your proprioception. I'm sorry, you do have characterized by proprioceptive sensory loss, right? But preservation and pain intent. So yes, I said it right. So you do lose your pain and you lose your proprioception and some of your motor, but you keep, hold on, I'm saying this wrong. I'm getting my words mixed up. You lose your proprioception, but you keep your pain and temperature, sensory, and motor function. Yeah, okay, I said it right. I was trying to say it too fast. This is usually not due so much to an injury, but this is usually due to like an artery occlusion on the spinal cord, or like a tumor on the spinal cord, or if there's like a disc that's compressing the spinal cord. Now, if you also know the discs, if you're looking at the vertebrae from the side, the discs sit in front of the spinal cord. So a disc, if it's herniating, is more than likely going to hit the front of the spinal cord than the back of the spinal cord. But if it's compressing the front of the spinal cord, it can push the back of the spinal cord back against the vertebrae, and then that's where the compression can come from. Also, vitamin B12 deficiency can cause this too, but the big ones are going to be spinal artery occlusions and tumors. We talked about sacral sparing. So I already said something about this, but let me see where we're at. Cauda equina. Yeah, we'll stop after cauda equina. Let me go back. Sorry, going backwards in time here. Okay, before we get the cauda equina, what is my computer doing? Okay, this is where I meant to stop. I promise. Thank you. Sacral sparing. So sacral sparing means that S4 and S5 were basically spared. So I have that reflex, I have that control. So what's the big deal? If I have any spinal cord injury, say it doesn't really matter what level I have the injury at, but if I have sacral sparing, what's the biggest clinical importance of that somebody might can guess? I said it earlier, but I've said it in a different way, so maybe you can think about it now. Think about what those sacral nerves are going to be controlling.
They can still control bowel movements and like urination.
Exactly. That's what I wanted to hear. So if you have sacral sparing, that means that you can control, well, right after an injury, you might not completely be able to control your bowel and bladder, but you do have some control over it, and you're more than likely going to gain full control over it. Now, if you are a complete lesion and you don't have those reflexes and that sensation, then you're not going to be able to control those things, and you'll have to be capped, every few hours for the rest of your life, or have a port put in, and you'll have to have a bowel program where you have to, where your bowels will basically, you'll go like every morning or every night on like a timed basis, and you can train your body to do that. But if you have sacral sparing, you don't really have to worry about all that, but we'll talk more about that soon. One more type of spinal cord injury, and then we'll take a long break because we've been over an hour now recording. Called Aquinas Syndrome. This is the only type of spinal cord injury that is a lower motor neuron lesion. So the spinal cord honestly ends about L2. That's about the end of where the spinal cord ends. Okay. Anything, so if the spinal cord ends at L2, but we all know we have an L3 nerve, we have L4, 5 nerves, then we have S1 to 5 nerves on both sides. So we know we have more nerves below L2. Those are going to be lower motor neuron nerves. So that if you have a spinal cord lesion with those nerves, it's all going to be lower motor neuron, and it's going to be a completely different kind of sensory, or completely different kind of impairment presentation. So if it happens suddenly, you're often going to just go floppy. You're just going to lose lower extremity strength and function. You'll lose control of bowel and bladder, and you'll lose your sensation too. Now, usually Aquinas syndrome injuries are not sudden injuries. They're slow and progressive. Okay, they're slow and progressive because they usually come from spinal stenosis. They come from spinal tumors, either bone tumors or spinal tumors on the spinal cord themselves, osteophytes growing in the spinal canal, stenosis, things like that. So they come on. Aquinas injuries usually come on slowly, and they usually come on asymmetrically and unilaterally. And you're going to start getting usually the first effects, you'll start feeling low back pain, and then you start getting sensory, like tingling, and like sensory impairments and sensory losses in your genitals and your pubic region, all up and down your legs, maybe in your back. You might start feeling some weakness, but the first thing you're going to feel is sensory loss. That's the first symptom of cauda equinus. You can look that muscle atrophy and weakness is really, really big. Bladder involvement, and you usually have a flaccid bladder with this, which means your bladder can't fill itself up and just hold itself. It's just always going. It never fills up like a balloon like ours does. It's just is always going. Okay, so I think we'll take a break here. So we've been going a while. This is a good stopping place. So let's take a good 10-minute break. So I've got 1:33. So let's come back at 1:40. So 7 minutes or so. And then we'll keep going. Okay. And then if you have any questions, I'll sit around. If not, I'll go take a break too.
Mr. Allen, you're still muted.
Yeah, Mr. Allen, you muted. I thought it was me.
That might help. Can you hear me now?
We can hear you.
Okay, so now here's the slide again. Sorry about that, guys. Okay, so I'll start over. I didn't say much. So right after a spinal cord injury, no matter what type of injury you had or what level you are, you're going to go through a small period, what we call spinal shock or areflexia. And if you remember back in the stroke, talking about strokes, they also go through a period of what we call areflexia, where they're going to be floppy and hypotonic for the first few days or a week or so. Well, that's how people with a spinal cord injury will usually be immediately following their injury, and it'll last a few days or a week or so. They'll be pretty flaccid. They won't have spasticity. They won't have, their reflexes will not be hyperactive, and they might actually be gone.
Mr. Allen, are you screen sharing? Because we don't see anything.
I'm not having a good day here. I totally thought I was screen sharing with you.
It's okay, Mr. Allen, we got you.
I'll probably think I had a TBI or something. Okay, let's do some testing. Can you hear my voice and can you see my slide?
Yes.
Okay. I don't feel so stupid anymore. At least y'all heard what I said. But that first few days to week or weeks will be called a spinal shock or areflexia. And then things start to happen. After that, then after about a week or so, then your spasticity will start to kick in. Your DTRs will become hypertonic. You'll start to be able to, you actually might develop a little bit of movement from spontaneous healing, but sometimes spinal cord injury people will use their spasticity to their advantage to use it to do things. So they can do that too. But anyway, that happens. Another thing that happens is called autonomic dysreflexia. This only happened, this is a dysregulation of the autonomic nervous system. Now this is only spinal cord injuries. These things can only, the autonomic dysreflexia is solely for spinal cord injuries, and it can only happen if your injury was at T6 or above. Okay, so if you have a spinal cord injury and your level is anywhere at T6 or above, then you're going to be at risk for having autonomic dysreflexia. But if it's T7 or below, you will never have autonomic dysreflexia. But what is it? Okay, so it's dysregulation of your autonomic nervous system. So there's lack of inhibition from higher centers of the brain. So basically, there's some kind of stimuli on the body below the level of injury and it might be, say, something that we might consider painful, like say like a rock in your shoe, or they're sitting in their wheelchair and their leg is resting against the leg rest, and something is maybe a screw is poking them in the leg or something. Well, they can't feel that because it's below their level of injury. However, the body can still senses that. Well, the brain completely freaks out, okay? And the autonomic nervous system goes completely into overdrive. So they're going to have automatic, and this can happen within seconds to minutes, hypertension, and I mean deadly hypertension, that high, bradycardia, their heart rate slows down, they have severe pounding headache, really profuse sweating, like their whole body is sweating. Their spasticity will suddenly get a lot worse, like their whole body almost. They'll become really restless and anxious all of a sudden, like they just won't be able to sit still, and they'll be real nervous. Sometimes their pupils will constrict. Sometimes their vision will get blurry. These symptoms usually come on. This is not something that happens like over time. This is an acute attack, okay? So this is an acute attack by the brain because it thinks, oh no, something bad is happening to the body. There's something painful happening. I've got to take care of this. But even if it's just something minor, like say the patient's leg is leaning against and getting poked on the wheelchair leg rest, the brain doesn't have the spinal cord connection to tell it that's not a big deal, so the brain freaks out and the brain makes all these things happen. So a person that goes through autonomic dysreflexia can easily die, okay? They can die from a stroke, from the hypertension and the heart attack. They can die from nasal congestion, not being able to breathe as well. The blood pressure and the bradycardia are the biggest, most life-threatening ones that you got to deal with. So what other things that lead to this? Sometimes if somebody has like compressive stockings on to keep their blood pressure up, they'll have compressive stockings on to keep them from getting blood clots and from getting keep their blood pressure up. Say they do have a blood clot or those compression stockings are too tight, the brain can read that as a noxious stimuli, and you don't know what the brain is freaking out over. But when the patient tells you, oh, I've got like a bad headache, and then they start sweating, you can start telling that they're sweating and that they're breathing different and their spasticity is increasing. You better take their blood pressure. First thing, do not lay them down, because if you think about it, if somebody's blood pressure is super high and then you lay them in supine, well, you're making more blood go to their brain, and that's going to make their blood pressure in their brain even higher. So you want to keep them upright. We want to drain as much blood from their brain as we can, because it's already too much pressure in there anyway. So you keep them upright, okay? And it doesn't matter if you're in the middle of the therapy gym or you're doing a home health session, you start stripping away stuff off of them to see what is causing the problem. It could be maybe their shoe is laced on too tight. It could be that they've got a wrinkle in their sock. And I mean that when I say that. It could be a wrinkle in their sock that their foot has been on all day. It's caused a stage 1 pressure injury already, and now the brain is freaking out and goes crazy with autonomic dysreflexia. It could be that simple, or it could be something as severe as their bladder is full. Well, if they don't have control of their bladder and they can't empty their bladder, then they need to be cathed emergently. So you need to ask them, when was the last time you were cathed? So when they're in the rehab hospital, they're getting catheterized every 3 to 5 hours. Okay, that's about how often that our bladder normally empties itself. So they're trying to get the bladder on a schedule to empty itself like that. Okay, so they're cathing intermittently every few hours. And if the patient says, oh, it's been about 4 hours since I've been cathed, or if they say it's been like 6 hours, well, it's time to get cathed. So you transfer them back into their chair, or if there's a gurney there, because autonomic dysreflexia is usually a code you have to call, and it's a medical emergency. You get them on a gurney and you get them back to their nurse's station and get them cathed. Or if they have a Foley catheter in, you will be able to look at it and tell if it's full or not. I don't care where you are, if you're in the gym or if you're in their living room, you grab a cup or you grab a basin and you start emptying that thing, because if their catheter bag is full, there's nowhere else for that urine to go, and their bladder is trying to empty, and that bag is full. So there's nowhere to go, and it's backed up, and it's coming back in the body, and the body doesn't like that. So you have to take care of what's happening. Sometimes they need to be changed. Sometimes they've had a bowel movement and they're sitting in it and they don't realize it, and you don't realize it, but their body realizes it, and their body doesn't like that. So just know autonomic dysreflexia is something that when it starts, you better call emergency code and get a doctor there, get a respiratory therapist there, get nurses there, and get them to take care of that, because from there, it's a life-threatening thing, and they need to take care of it. It's going to be out of our hands. This is just bladder stones can cause it. UTIs can cause it. Pressure sores anywhere on the body can cause it. Even environmental temperature changes can cause it. Like if they get too hot or too cold too fast, it can cause it. So it can be a lot of things. Other things that happen with spinal cord people: postural hypotension, otherwise known as orthostatic hypotension. And this would be for a couple of different reasons. So partially because, by the time they get to you for therapy, they've been in a hospital bed for days or weeks. So they have some atrophy, muscle atrophy. They've got decreased cardiorespiratory endurance now, just from being immobilized and not walking around and being in a hospital bed. But also because most of these people have had neck or spinal surgery to stabilize their spine, they're going to have to be in seat cervical collars or body jackets, which are called TLSOs, which we'll see later. They're going to have to be positioned in supine for a long time, usually the first few days to week or two that they're healing. So they're going to be really deconditioned, even if they're not in bed a lot. They're just not up in upright as much as we usually are. So we're going to get them on the mat and start doing sitting balance and all these things with them. And after about 10 minutes, they're going to start getting dizzy because, well, that's about as much endurance as they've got. So we're always going to be checking blood pressure. We're always going to be checking blood pressure before a session, during the session, multiple times during the session. Hypertension is really big with spinal cord injuries. The newer the injury, the bigger of a deal it is, but it can be a big deal their whole life. Now, what can we do to prevent this? Support hose like TED hose that people use to prevent blood clots. We use compression hose that squeeze the legs, that can keep the blood pressure up. Some go up to the knees, some go all the way up to the thigh. They're pretty tight. This is ACE wrapping of the lower extremities. You can do that, but that's not really that effective. Abdominal binders, the first thing that it says there after intervention, that's basically like a big giant elastic girdle that goes around your whole torso, and it's a big piece of elastic with Velcro, and you wrap it around you really tight, and somebody has to do it for you. But it's pretty snug, but it's snug enough that it keeps the blood from your abdomen and from your belly from pooling, and it keeps it up in your central circulation. So all these things together, really, these people are going to be wearing these articles of clothing for a long time during rehab. Other things you can do, we're getting on the progressive standing device, what we call a tilt table or a standing frame, and that just starts them in supine. Let me see if I got a picture. Nope. It's like a table that starts them at supine, and you can slowly increase the angle to where they can stand up at 10 degrees of inclination, 20 degrees, anywhere up to 90 degrees, and that's all the way standing. And you would take their blood pressure up to say you want their first day of being upright. You might put them at 30 degrees of incline, and then take their blood pressure every minute. And then after 10 minutes, their blood pressure is dropping. They're orthostatic. So maybe you go down to 20 degrees. of incline, and then take their blood pressure again, and they're stable. So you would stay there until their blood pressure stabilizes, and then you could try to go up to 30 degrees again and see if they could stay there. You would do that over several sessions until they could tolerate fully standing up. Spinal cord injury people have impaired temperature control, usually below the level of their injury. That has to do with the hypothalamus in the brain having no control over the blood flow and sweating. So they're not going to sweat. They're usually not going to sweat below the level of their injury, and they're not going to have any temperature control below their level of injury. So this last bullet might sound weird, but it says patients need to be taught to rely on sensory input from head and neck for temperature. That would be reserved for the people that have spinal cord injuries where they have like a high injury, like a C1 or C2 injury, where they can't do anything but move their head and shrug their shoulders. They have to rely on their face to feel the temperature, but everybody else would just rely on whatever they have left. Respiratory impairment can be a big deal, not for paraplegias, but for tetraplegias. Now, if you remember, let's see, is it on this slide? It is. The phrenic nerve is the nerve that innervates the diaphragm, and the phrenic nerve is made up of the spinal nerves from C3, 4, and 5. So the spinal nerves from C3, C4, and C5. Those make up the phrenic nerve, and that's what allows us to breathe on our own. Well, if a person has an injury above at C3 or above, they're going to have impaired respiration. So they're going to be on a ventilator, at least at first. Now, people that have a C2 or a C1 injury, they're going to be on a ventilator for the rest of their life. People that have a C3 injury, they're losing just partial diaphragm innervation. They may be able to strengthen their diaphragm with their remaining innervation and maybe get off the ventilator. And a lot of those people do that, and respiratory therapy works with them, usually in conjunction with our sessions. And we'll do like a ventilator holiday for like an hour during the day, just sitting there still to see how their oxygen levels are, and then go back on the ventilator. And then we can try the next day doing respiratory therapy. Will be there with us, and they'll take the ventilator off, and we'll do simple physical tasks and watch their oxygen levels without the ventilator and see how long they can stay off. So we co-treat with respiratory therapy too, to get people off of ventilators. But if you are a paraplegia and you have lack of trunk control, you're still going to have some problems with coughing and with exhaling, because coughing, when you think about it, coughing is a reflex, or we can cough on command, but we do that with our abdominal muscles. We make all the pressure with our abs and with our intercostals. Well, if those muscles are no longer innervated, then we're not going to be able to do like a anymore. We're going to have a heh. That's what it's going to be like. We're just going to be able to barely exhale and push anything out. So we may need help getting with coughing, or we may have to learn how to do it's not the Heimlich maneuver, but almost like assisted coughing on ourselves, where a paraplegic may put a pillow around their abdomen and put their arms around it, and when they know they need to cough, they may push the pillow into their stomach to help put pressure into their abdomen to cough up anything they have, so they don't keep any phlegm or anything in their lungs. I won't go through this whole thing of spasticity. It's an upper motor neuron lesion, just like everything else we've talked about so far this semester. So you're going to have a lot of spasticity. like I said, that first week after injury, you're going to have a period of areflexia. So you'll be pretty floppy, but then it's going to, after that, it comes on pretty strong after the first couple of weeks. They usually say that it's whatever it is, your spasticity is at 1 year. It's not going to get any worse after that. And that pretty much is true. If your spasticity may progress over the first year after injury, but usually after about a year is as bad as it's going to be. Now some spinal cord, now this is where things change a little bit with what I've taught you. Now before, like with brain injury and stroke and other diseases, I always told you, never let somebody learn a compensation method. Always teach them to do things the right way, force use. Don't ever let somebody take a shortcut. Well, sometimes, and a lot of times with spinal cord injury people, we have to let them take those shortcuts, and we have to teach them compensations because their spinal cord's not going to really heal. I mean, think of a big, thick electrical cord. If you have an extension cord that's the main electrical power line of your house and it gets pretty damaged, I mean, it's damaged, and we can get better, and we can teach skills to do things better. But the spine, and there's a little bit of neuroplasticity in the spinal cord, but not like the brain. And there's not a lot of neuronal resprouting in the spinal cord either. So there's not a lot of healing in the spinal cord. So that's where this middle bullet says some spasticity can be beneficial for mobility. So it's kind of weird. Some patients, they can learn what triggers their spasticity, and they can use that to their advantage. So like an example would be, like if they know that if they do a certain movement, or if they do like if they throw themselves forward and lean forward real fast, that it makes their legs go into extension and makes their quads turn on. They may do that trick to make their quad spasticity come on during a transfer, and then it's almost like they're doing their transfer with quad strength, even though it wasn't quad strength, it was all spasticity. But that's the way some people learn to do their transfers, all independently. They trigger their spasticity to kick in, and then it makes their legs stable for just that few seconds where they can do that squat pivot over, or that sliding board over. Same thing for the arms too. They can trigger extensor spasticity, or they can get their arms in a position where it'll lock, their elbows will lock, even though they don't have the strength, the muscles for it. They can do certain tricks or compensation methods to do little shortcuts. Now, there is a certain degree of spasticity that will limit your function. And these medications that are on here, these are the same medications that all neurological people take for spasticity, not just spinal cord injuries, but you have some diazepams like Valium. Now, those are more for anxiety. They're anxiolytic drugs. Those are for more calming a person down. They do have an effect on spasticity, but they make the person super sleepy. So if you're about to go to therapy and you want to take your meds so your spasticity will go down, what's the point of going to therapy if you're half asleep on Valium, but it made your spasticity better? And then also, if you have a brain injury and you have spasticity and they've got you on Valium, you're going to be totally out of it, on top of your cognitive impairments, and your therapy is not going to be much good because you won't be able to pay attention. Another drug is called Baclofen. Baclofen and Botox are probably the most common drugs that are given for spasticity. Botox, as you know, is an injection, and Baclofen can be injected into the spinal cord, or it can be an oral pill. The oral pills do make you a little bit sleepy, but not as bad as the diazepam. So some people can make it through life on oral Baclofen, but some people have to get what we call intrathecal baclofen, or an ITB pump. It's a pump that's about the size of a hockey puck, and it's literally filled with liquid baclofen, and it's implanted in their body, and it delivers the medication directly to their spinal cord. It's a lot more efficient than oral baclofen, and it bypasses the brain, so they don't, and like the digestion, so they never get any of the side effects of the what am I trying to say? Being sedated or tired. So that's why a lot of stroke and TBI people will have a lot of the baclofen pumps, and spinal cord injury people will usually take oral baclofen, because they can take the side effects of just being a little bit sedated, and they usually get used to it. Peripheral nerve blocks, they can get alcohol nerve blocks, like what's something called phenol, or different nerve blocks that they can get injected directly into a nerve that'll basically paralyze the nerve. So the spasticity will be gone for 3 to 6 months until that nerve regenerates. They can do surgeries if the spasticity is so bad that it interferes so bad with a person's life and no amount of therapy is helping with it. That can actually go in and sever nerves or cut tendons, so that the spasticity will just no longer be there anymore. But that's always in a worst case scenario. They used to do that a lot more often. That's the name of these procedures at the bottom. They do those now sometimes with kids in cases of like severe spasticity, like if they've had a hypoxic injury, or if they've got really severe CP, they may do cuts, they may sever nerves or sever some tendons. But usually those kids do get the pumps too. I'll try to send y'all a link about the pump. It's pretty cool. I already talked about bowel and bladder dysfunctions with with S4 and S5 being complicated. So yeah, if you have a spastic or reflexive bowel and bladder, where you have to get put where it kind of empties on its own every few hours, or you can get put on a schedule, then you have an upper motor neuron bladder. It's called a spastic or a neurogenic bladder and bowel. In that case, your bladder and bowel will fill up, but they just fill up, and you never know you got to go, because you don't have that sensation, you don't have that control, so they just fill up and fill up and fill up. Well, that can throw you into autonomic dysreflexia. So that's why we do timed voids, which was what I was talking about earlier, getting cathed like every 3 to 4 hours. And they do their bowel program once a day or every 2 days, and they'll do that at the same time, and they'll take usually a suppository, and they'll get themselves over their toilet seat, whether it's just a regular commode or a raised commode, or a toilet bench, or a something to roll over their shower, which is what most of them have. They'll take their suppository at a certain time at the same time of day, and then it'll be fast acting, and then their body will go. And then after so many months, their body is used to those times a day, and their body gets used to telling them, like, and then it's almost like they know. They don't feel the same sensation that we do, that they've got to go to the bathroom, but they know, oh, I have to cath now, or I have to go do my bowel program now. And then, but the body gets used to this, and it keeps the body flowing regularly, keeps the bowels flowing. Constipation is really a dangerous thing for spinal cord injury people. It can cause autonomic dysreflexia. And I mean, if you're having autonomic dysreflexia and it's from constipation, I mean, you really can't do anything that quickly to get rid of it. So it can be super dangerous. Nursing and OT are usually the ones that take care of the bowel and bladder programs. Sexual dysfunction is a big deal, as you would probably think. Not just the physical impairments that go along with it, but the psychological impairments that go along with it too, because I mean, you know, we're adults. Sex is a normal ADL. It's part of our life. It's part of what we do. It is considered an ADL. And if you have that if you can't do that anymore, or you have part of that taken away from you, or it's something's different, yeah, it's going to affect you psychologically. You're going to get depressed, and then it might affect your relationships. So those issues need to be treated in rehab too. So when I worked at Tier, we had a sexuality, an ongoing sexuality class for spinal cord injury patients and their families, that they could go to. And it was usually like once a week, like for an hour. And they just talked about different issues. Sometimes it's just things like, sometimes it's as simple as if it's a male with an injury, they may have to take an erectile dysfunction med the rest of their life. That might be all that may be to take care of it. Women can still become pregnant if they have a spinal cord injury and carry a full baby to term, but being pregnant does carry its risks with autonomic dysreflexia sometimes. But the sexual part of their life is just as important as it is for our life. So they need to have social work involved, neuropsych involved, counselors involved, and there's a lot of OTs that specialize in sexual dysfunctions after impairments and disabilities. So getting them hooked up with these people is really important too. So if you're in a little clinic or a rural place and there's not anybody that in your place that is there to discuss those issues, you know, you may breach those issues with your patient, but you know, you may just be the one giving them the resources. So finding the things on the internet, calling around within your organization, asking social workers for information, or calling other clinics or just doing research on your own and just giving them the research, or just pointing them to websites and letting them do the information on their own. Pressure sores, we won't talk about this much. You know all about pressure sores and the different stages. You know, in bed, you've got to be turned a minimum of once every 2 hours. Well, when people are in their wheelchairs, they need to do a pressure relief every 30 minutes for 1 minute. And there's different types of pressure reliefs. It all depends on your neurological level and what the muscles you have left. If you have triceps and lats, you can just put your hands up on your armrest and push your butt off the mat. Push your butt off your seat, and then you do a pressure relief like that. Just hold yourself up, and that's all you got to do. Some people, if they don't have those muscles innervated, they have to lean over one way. So they'll lean over one armrest and unweight one ischial tuberosity for a minute, and then they'll lean over the other side and unweight the other IT for a second. And then some people might lean forward to unweight more of the sacrum, and then they might lean back a little bit too. So there's different ways to do pressure reliefs. If a person can't do it, then the patient's caregiver has to be able to do it in the tilting. They have to tilt their chair back for a minute to do it. Pressure sores are very common. Pressure sores are very common with spinal cord people. They're gonna get them sometime in their life. It's just inevitable. They're gonna get at least a stage 1 or a stage 2. Now they should never get to a 3 or a 4. That's just neglect on the caregiver's part and probably the patient too. Now I have seen 2 stage 4 wounds on the sacrum. Both guys, spinal cord injuries, and they were in their 30s, and but one was because he got drunk and on the couch and he was wearing jeans. And you know how on denim jeans, how on the back where the seam comes together, it's real thick. Well, that was right over his sacrum, and he was laying back kind of slumped. Well, he slept like that all night and never moved. and none of his friends thought to move him. They just left him there. And so he developed a stage 4 pressure wound over his sacrum. I mean, I could see bone on this guy, and this wound grew this big. It was huge. Once it started growing and tunneling, it got big. The other guy was drug related. He just passed out, and he had a giant wound over his greater trochanter. And I literally watched, and he was a spinal cord injury guy. He just fell asleep and sideline, slept all night in it. And over his greater trochanter, I could see his entire greater trochanter. No, just tendon and just atrophied muscle barely hanging on to it. It was so disgusting. And he'll probably never be the same again. They'll have to have lots of plastic surgery for that. So the big moral of my story for this slide is never let that happen in the first place. These are some cushions that are used. They have specialty cushions to prevent pressure injuries. So these are Roho and J are actually brand names that you may hear, but there's different brands of these same cushions. Now a Roho cushion is those little chambers that you see. That cover is pulled back so you can see the chambers. They're all filled with air. So this is like an air cushion. Air cushions are the best type of cushions for pressure relief because basically you're floating on a cushion of air. But think about it. If you have poor trunk control and you're flying around in a power chair and you hit a bump and you're on a cushion of air, well, your trunk can't hold you up and your trunk is just flying all over to every side, and you might fly over the side of your armrest if you can't control your trunk, because air cushions are not that stable. So you do have to have a certain amount of trunk stability to sit on an air cushion. Now a J cushion is made of gel and foam on the inside of the cushion. And then a gel cushion is just gel all the way around. Most patients do sit on a combination. Some of them might have both types of cushions, and they use them at different for different activities. Gel cushions, I would say, are probably the most common because they're used with all diagnoses, not just spinal cord injuries, but TBI, stroke, MS, Parkinson's, and all the other stuff we'll talk about too. And these are by far not the only types of cushions. There's air cushions that are like half air, half gel. There's all kinds of specialty cushions out there, but you'll learn about those on the job. So don't think you need to learn about them just yet. These are different types of manual wheelchairs. We'll learn all about different types of specialized wheelchairs next semester. You know, the wheelchairs we have in lab that fold up are really like not for any type of certain person. They're just like to get a sick person from point A to point B. These chairs that you see on your screen here are specialty chairs that most of these are for spinal cord injuries. So they're lightweight. They're much, much lighter. They're either made of aluminum or titanium. And so they're much lighter for a patient to push around, and they're much lighter for a caregiver to push around too. Now you can see this one in the middle is leaning back into a reclined position. Now that's one way that a person can do a pressure relief. If they're in a chair this big, then that would be a person that needs a lot of help. So their caregiver would push some buttons on the handlebars and they would lean them back. There's other chairs. Let me see if it's on the next chair. Yeah. No. These are manual chairs. There's other chairs that are called a tilt and space chair, where it doesn't recline back like that, but the whole seat and like if this is the seat and this is the backrest at a 90-degree angle, instead of the backrest just reclining, the whole seat and chair recline on its own. So your back and your hips still stay at a 99 position, but it takes pressure off of your ITs and puts it more on your back. So, and that can be manually done or in a power chair too. Here's some really basic power chairs. These are some just non-custom power chairs. You'll learn all about custom power chairs next semester from me. when we get to that topic in special topics. There's front wheel drives, there's mid wheel drives, there's rear wheel drives. They all have different specializations. Don't worry about it right now. We'll learn the different reasons for different drives next semester. But chairs can be operated by, you can see here, these chairs have joysticks on them that are just like what you might think about. Some people that don't have, some people are going to be able to drive, but they don't have any hand control. So they may be like a C1 or a C2 injury. Well, those people may have these devices to drive their chair. So if you look, let's start up at the upper left, right or left, upper left-hand corner at a black and white picture. Looks like a straw coming out in front of the wheelchair. That's called a sip and puff electric chair. So what the person does, the person can totally drive and maneuver the chair forward, backward, sideways, turning, go over obstacles, up and down ramps, through doorways, all by blowing through a straw. And it all has to do with the pressure that they're blowing through the straw, whether they're inhaling or exhaling. They can do quick puffs, they can do quick inhales, they can do quick exhales, and that's how they learn to drive the chair. It's hard to learn to drive like that, and I've seen people being trained on that, and they do run into walls a lot, and there is a big learning curve with that, but they can get it. And I actually have a second cousin that is a tetraplegia, and that's how he's been a tetraplegic for a really long time, like before I was born. And sip and puffs have been around for a long time, so that's how he drives his chair. He probably would drive with these other mechanisms that you see if he learned them at the time of his injury, but they might not have had them then. Below that one, there's a picture, and it looks like a headrest with little head supports on the side. That would be known as a head control array. So these headrests have sensors in them, and depending on the pressure of the sensor that you put, drives the chair. So there's pressures on the back. There's different sensors on the back headrest for driving forward and backward. If you want to make a turn, you would turn your head and put your head on the side. Lateral side links, lateral supports, and those can be adjusted and put anywhere on the head. You can do it with your forehead, you know, with your cheek, your chin, just whatever moves the best and is easiest for you. This last one, this other black and white one, this lady is moving, this is called a chin control. This one is a little weird. You just drive with motions of your chin, but you can't talk when you're doing this one because you're always using your mouth, and you can't talk when you're using a sip and puff either. So that's kind of is the disadvantage of those. This other one up here that's looking into a person's mouth, that's actually a control pad that is on the roof of their mouth, that's stuck on the roof of their mouth. Now, it's not stuck on there permanently. It's probably just like a adhesive they use like glue every day to put it there or something. And the sensors are there for driving the chair, and it's all wireless, and they drive it with their tongue. And they learn how to drive the chair and they have to memorize the different buttons on the sensors in the mouth have different textures, and so they learn how to drive the chair with their tongue, like that. Can't talk while you're using that one because you're busy using your tongue. I would say, as far as power chairs, the most common types of usage of, propulsion systems or propulsion arrays are going to be joysticks, because even people that just have one finger, if that's all they can move, you can drive a joystick chair with one finger, or a head control array. Those are the most common types I've seen. Those are the most easily learned to use and drive, and so that's where most people end up using them. You'll know about HO, herotopic ossification. This is just when bone tissue grows in a place where it's not supposed to grow, usually inside of a joint or inside of a muscle. I'll tell you, it happens a lot inside of the knee joint, and it happens a lot inside the quads too, with spinal cord injury people, and it also can happen in their glenohumeral joint too, and they'll get bone growing in there too. When it starts, they have to start them on medication to try to either stop it from growing or manage it to kind of slow it down. They can't do surgery to resect it until it's done growing, or it'll grow back. Once they manage it and they watch it by doing periodic x-rays like every 2 or 3 weeks or a month. Once they can determine that it's not growing, then they'll go in and do the surgery to take it out, because then it's not going to grow back. You can kind of see these are x-rays, and these are pictures of HO. This knee joint, you can see where the patella is. All that cloudiness up above the patella, that's the end of, that's where all the quad muscles are coming together. That's actually HO growing into the quad, and you can see a little bit of it below the patella, like right growing inside the knee joint, kind of in front of the femoral condyles. You can kind of see a little bit there. And on this other picture, the hip joint, you can see there's a little bit of it growing on the lateral side of, right on top of the greater trochanter, and you can see a little arrow that's pointing to, that's the HO that's growing there. Other things that, and now we're closing up here pretty soon. Other things, people go through pain. You can have nerve root pain just from, it's a spinal cord injury is a nerve injury. So you could have neuropathic pain the rest of your life. You might have to take pain for those impairments, and it might not be like true. They're right. It might not be because something's actually stabbing you in the foot, or because you're having ants or tingling on your foot, but it's the paresthesia, and pain can drive you crazy. And also, I mean, it's annoying. So let's get rid of the pain. Spinal cord injuries are real, guys. My puppy's chewing on something plastic. Give me 1 second. No, Cooper. Give me that. Sorry. Didn't want him to choke. People with spinal cord injuries, or anybody that is not up and walking around as much as an ambulatory person, if they're more of a wheelchair user, they're going to be prone to developing osteoporosis, just for the mere fact that they're not putting weight bearing through their pelvis and their legs as much. So if you go by Wolff's law, which says that bones grow by force placed through them, well, there's not as much force going through them, so they're gonna lose bone mass, unless they're in a standing program, like in a standing frame at home every day, which we want to encourage them to get a standing device, and we can help them do that in therapy before they go home, where they can maintain their bone density. And a standing device is very good for maintaining muscle density, decreasing spasticity, and stretching you out. You can develop kidney stones from this, just because you're not up and moving as much. So the calcium coming out of your bones is being filtered through your kidneys, and it can develop kidney stones. Contractures, especially when spasticity is present, is always a big risk factor. So there's always going to be splints and things that are going to be worn. A lot of them were positioning devices at night to keep their spasticity from keeping them in a bad posture at night. So a lot of them will wear like ankle splints or ankle or wrist splints while they're sleeping at night for the rest of their life, because if they don't, their spasticity will shorten their muscles overnight, and they'll be really, really stiff, and that adds up every night, and then eventually they'll lose a lot of range of motion. They're more at risk for DVTs because they're not walking as much. They're more at risk for depression. I mean, obviously, because they've lost their ability to walk in most cases. Socioeconomic changes, I just put that on there because they may not be able to go back to the same job that they had before, or if they do, they may have to change roles at their job, or they may have to take a different type of job and it may be lower paying now. You know, with the ADA taking effect, pretty much nobody can be turned away from a job. But I mean, there are certain jobs that you have to be able to do. You have to be able to stand up. You have to be able to do those things, and you know, for a certain amount of time. And if you can't do those things, you might just have to take a different position. I mean, that's sad, but it happens. The prognosis, you've probably been wondering this all through the lesson today. How will people get good? How do I know if people are going to get better? It completely depends on their injury level, the severity of their injury, all their other comorbidities, and their body weight and their body structure. It depends on how active they were before they got hurt. Depends on all that stuff. So just because two people have the same type of injury to the same place, they can have totally different outcomes, just like with strokes and brain injuries, but maybe even more so with spinal cord injuries. That can maybe be even the prognosis can be more variable. Now, where this prognosis, you can kind of say prognosis can kind of be, you can look at it as, you know, how better is a person getting in the first 6 months, how better is a person getting in the second 6 months, you know, up to a year. Now a person can let me say this, and I've said this in other presentations before too, a person can always continue making changes and always get better, but most changes that they're going to make and most healing that's going to take is going to take place in the first year, as long as they're getting the right type of therapy and right type of body stimulation to their systems. Okay, so you can look at if they're working really, really hard that first year and they're getting a lot back and their spasticity is not holding them back and they're getting motor return back and they're getting functional things getting back little by little, that's a good prognosis. And if after a year they've come pretty far and they're still making gains, well, that's a good prognosis. But if it's been a year and they're battling spasticity really, really bad and that's holding them back, you know, then that's not a really good prognosis. Also, you know, I mean, you know, if you have the higher up your level your injury is, determines your prognosis. So you have a C2 injury, the only thing you're going to be able to do is rotate your head, hold your head up, and elevate your shoulders, and blink your eyes and talk. You'll have to be on a ventilator your whole life, so that's not a good prognosis. But if you're a T7, then you'll be able to you have full control of your arms and your respiratory system. You don't need a power chair. You can use a manual chair, and you can pretty much do any job that you need to do. So, you know, it's just variable. And so if somebody asks you, how much better am I going to get? Or the one question that I hate to get asked, am I ever going to walk again? You know, all you can say is it really matters on how hard you work and all these other factors. So we just have to see what's going to happen. I will let you read through this. This is just what's happening in the acute care hospital, what they're doing in the emergency room. They're doing spinal fusions, fusing vertebrae together or decompressing the vertebrae. Here's some of the stabilizers they may put them in. These body jackets that look like turtle shells are known as TLSOs. That stands for thoracic lumbar sacral orthosis. There's also cervical collars too. There's not a picture of it on this one, but if you look on your upper left hand side of the screen, there's a body jacket that's got it's got a lot of metal bars going around, and it looks like it has a headpiece on it. Well, that actually is a headpiece. That's called a halo. That's a really archaic type of orthosis to wear. But if you have enough spinal instability to where like you had some vertebrae that were just like disintegrated, or you have several segments that had to be fused together, they may put you in a halo device which fuses your head, your cervical spine, and your thoracic spine together completely. You cannot move from the waist up. I mean, you can move your arms because they're sticking out of the, you can move your arms, but you can't move your head, and you don't have any trunk rotation at all. That's whenever you have a lot of spinal instability that needs to heal for a long time. Those are really archaic. You don't want to be in one of those. MAT program. Now, what do? We're going to start first working on sitting balance. Now, I said sitting balance before bed mobility, because bed mobility, if you don't have abs and you don't have anything, then that's going to be really hard to start rolling over and bridging. But if somebody can hold you up in sitting and give you, and they can give you a little bit of PNF or a little bit of facilitation, that's enough to get some stimulation through your brain, to give a little bit of activation through your core. So I would start with sitting balance stuff first. Lower extremity management, where that says leg straps, that has to do with going from like a sitting position all the way to supine, getting your legs up on the table. If you can't use your arms to throw your legs on the table, we would used to make leg straps out of canvas at Tier, and we have some of that, or you can use like a stretch strap, or like a dog leash, and put it around your leg and throw it and pull it up on the bed or pull it off the bed. It's a way of compensating, but these people need to do that. Lots of range of motion to prevent contractures and to teach them how to do it. Lots of transfer training. All spinal cord people are going to need, where it says prescriptive wheelchair, they're going to need a custom wheelchair, whether that's going to be manual or power. And that means that the frame is going to be custom to them. The cushion will be what they need, and the backrest will be what they need. And everybody gets something different. Everybody's body is different. And then we got to work on wheelchair mobility, actually driving the wheelchair. So you may look at this list. I see orthotic prescription, like that's for braces. Standing programs, they need to be able to stand at some time in some device at home every day, or if every other day. Weight shifting for pressure relief. We can do weight supported treadmill training, like you're going to see in your clinicals. Family and patient education throughout their whole stay. We educate them on their home exercise program. We educate them on range of motion that we do. We educate them on transfers, because we can't go home with these people. They're going to go home. So once they get home, who's going to be doing the transfers? Their spouses, their kids, the hired caregiver. So we're there to train them. So we're the teachers too. And we've got to figure out if they need any home modifications. So we've got to get them to take pictures with your phone of your entrance to your home. Do you have any steps? How wide is your bathroom doorway? What kind of bathroom or bathtub or shower do you have? What kind of equipment do we order? We have to do a lot of that kind of stuff. So if you're looking at this list, you may wonder, well, where's the gait training on here? Well, I did say weight supported treadmill training, but when a person first gets a spinal cord injury, the very first few months of what you're doing is really trying to keep them functional and get them independent in a wheelchair and get them as independent as possible. Now that doesn't mean if they have activation in their legs that you can't use it, or even if they don't have activation in their legs, to not try force use, because you can do those things. But we need to get these people, the very first things we need to get them to do is sitting balance, bed mobility, transfers, doing their own range of motion, doing their own home exercise program, doing their own weight shifting, teaching them how to propel their wheelchair up and down ramps, around obstacles, through elevators, through doorways, to get ready for going home, to get ready for the community. We'll do gait training. They can do that in outpatient, or they can do that later during another stay. We can phase their stays, or they can work on outpatient for gait for a long time. But just as long as we need to get them as functional as possible before we start working on the little things like perfecting their gait. Now, if they have a minor injury and they're in the hospital with you at first and they've already got lower extremity activation and they can stand a little bit, it's okay to start working on gait training then. That's okay. They're not going to have the endurance to go very far. They won't have the strength to do it, but you still are going to have to teach them probably some transfers and some range of motion, but not as much as somebody that was completely paralyzed in the legs. Last couple of slides here. Selective stretching. There's a couple of muscles you don't want to stretch out. Well, there's one muscle group you do want to stretch out really, really far, and then there's another muscle group you don't want to stretch out. So we always want to stretch out with neuro patients. Y'all look at my screen, my camera real quick. We always want to stretch out their wrist and their fingers so that they always have at least neutral, okay? We never want them to lack range to where they're in some flexion, okay? So with brain injury patients, with stroke patients, with other neuro diseases and injuries, we're always wanting to stretch those wrist and finger flexors back, keep them stretched out into extension. But in spinal cord level, and people that have tetraplegia, that means their arms are involved, we don't want to stretch those out all the way. So what we want to do, we do want to stretch them, but we want to stretch just the wrist flexors. So when we stretch them, we let the fingers flex. See, my fingers are still flexed here. And if we're weight bearing and doing forced use, we have them weight bear on flexed fingers if it doesn't hurt them. The reason we do that is because go back to in Introduction to Kines and way back in semester 2, I taught y'all passive insufficiency. So if we keep a little bit of tightness in the wrist flexors, let me see if I can get by my camera so y'all can see this. Okay, so if I have a spinal cord injury, I'm going to grab onto something. Well, I don't have C8. So C8 controls most of my wrist, my grasp, my wrist flexors. Well, I don't have that, but I do have C6 and C7, which are wrist and finger extensors. So if my finger flexors are a little tight and I extend my wrist, you can't really see it very good from my camera, but y'all all do that. Don't keep your fingers straight. Keep your fingers relaxed and just extend your wrist. What happens to your fingers? Somebody.
They flex.
They flex. That's right. Thank you, Willie. So we call this a Tennodesis Grasp. So I'm going to use a can here to demonstrate. So if I don't have the muscles to grasp my drink so I can bring it up to my mouth and drink it, what I'm going to do, I'm going to compensate. I'm going to extend my wrist and fingers so that my fingers will flex, and now it'll hold the can, and now I can bring it up to my mouth and drink. That's how those people will drink. That's how they'll eat. That's how they brush their teeth. That's how they brush their hair. That's how they do all kinds of stuff with their Tennodesis grasp, okay? So remember that. You don't want to overstretch the finger and wrist flexors. Wrist flexors are okay, but not the finger flexors, okay? Now, we do want to overstretch to contradict that. We do want to overstretch the hamstrings, because whenever most spinal cord people get dressed to put their pants on and their socks, they do it in long sitting, okay? They put their pants and their socks on with their legs sitting like straight out in front of them. So if you think about it, if you don't have long hamstrings, you won't be able to reach forward and pull your pants up, and you won't be able to reach forward and pull your socks up. So you need to have really long hamstrings. So if I had a spinal cord injury right now, I wouldn't be able to sit in long sitting and put my pants on or put my socks on because my hamstrings are so tight. So you would spend a lot of time on these people, all tetraplegics and paraplegics, stretching out their hamstrings to is this says to 100, but as far as you can possibly go, you know, without causing any problem. It's the more flexible they are, the easier time they'll have it. And besides overstretching the hamstrings, you want to overstretch the hip. Boys, no, sorry guys. You do want to overstretch the hip flexors too, because you don't want them to get a hip flexion contracture, and then they wouldn't be able to stand up all the way, and their pelvis would be stuck in a posterior pelvic tilt. So the easiest way to stretch out their hip flexors, and I don't know why I didn't put this on the slide this semester, just lie in prone. I think I said this in lab a couple of times last week. I hope I said it to both groups. Whatever your diagnosis is, lie in prone or prone on elbows for 10 minutes once a day or every other day. There's your hip flexor stretch. You'll never get a hip flexion contracture. It's a weird transfer. We're not going to watch it. There's the Asia score, and that's all. So that was today's lesson. Where did y'all go? I don't see you anymore. Threw a lot at y'all today. Where's stop share? There we go. So I threw a lot at y'all today. Probably the deepest information was the first half of the lesson. We were going through the different types of injuries and the different types of syndromes. And then the rest of it after the break was more, you know, functional stuff. Okay. So any questions on what I've went over with y'all so far?
No.
Okay, no questions. Okay, so there's one more thing, but I'm not going to sit here and read this to y'all because y'all are adults and you can read this. Let me pull it up, and you have this on Blackboard. Let me make it bigger first. Okay, it's a big chart. Screen share. Okay, so it's a big chart on Word, and what it does is it starts at C1 and C2, and it goes all the way down the list, and it tells you if you had an injury, if that was your neurological level, you go across the chart, and it tells you the most important muscles that would still be innervated, what your important movements that you would still have available to you, and then your functional capabilities, what you would be able to do. So let me give y'all let's go through how to read this. We'll start at the first injury, C1, C2. Okay, that's the highest injury you can get. So the important muscles that are innervated, well, all your facial muscles are still innervated, your neck muscles are innervated, and your cranial nerves are still intact. Okay. So what movements can you still do? You have limited cervical movement like flexion, extension, rotation, but you can do it. You have all your facial movements. Talking, chewing, you can do all that. And remember, you can elevate your shoulders. You can hunch your shoulders, because not hunch, you can raise your shoulders because that's a cranial nerve. That's not a spinal nerve. That's a cranial nerve. That's cranial nerve. Is that 12? I think, yeah. Functional capabilities. Well, the only things that I'll be able to do in this point are using my head, my eyes, and my tongue to operate a sip and puff or a computer or some type of phone or some type of power chair or bed. So something to do. I've seen some really cool computer systems that are hooked up to power chairs, and people have at home where they have like a little sensor that they put like on their forehead, and it's like a little metal dot that they stick on like a little sticky, or they either keep it on their glasses or they just put it on their forehead every day, and that's their mouse tracker. And the computer just tracks their head, and wherever they, like if they want to do a single click, they move their head, move the mouse to where it is, and they hover over for like 2 seconds, or I think it's like 2 seconds is as a double click and 1 second is a single click or something like that. They can type with all kinds of stuff like that, just using their head motion, stuff like that. Pretty cool. But what kind of assistance am I going to need if this is me? Okay, look at the chart. I'm going to be dependent for all self-care. So boys, everything, all self-care. I'm going to be dependent on a ventilator. But I should be cognitively independent with directing all of my own care to a caregiver. So, and my bowel and bladder care. Apparently somebody's breaking into my house and my dogs are going crazy. Now, slam the door on. So what that means is, even though I don't have the ability to do anything for myself, I'm dependent on people for all my self-care. I should be able to instruct somebody on how to take care of me. So say your spouse still works, and say my spouse works and I have a hired caregiver, and my hired caregiver, I have 2 of them and they rotate every other day with me. Well, let's say that one day they both are sick, or they both can't come in, or it's a weekend, and the agency sends somebody new that's never worked with me before. Well, they may have some experience with people like me, but to them, I might be a big job. Like they have to roll me from side to side, to change me, to clean me up, to bathe me. They have to feed me. They have to transfer me with a lift. So they may not know how to do all those things in their experience, but I need to be able to tell them how to do that so they can do that. So as a C1 or C2 tetra, I still have complete control over how I'm taken care of. And that's the same with all levels. Let's just do one more level and then I'll stop reading them and I'll let you do the rest of them. C3, C4, you have everything that C1 still has, but you have partial diaphragm innervation now. Okay, important available movements. Now you have diaphragm contractions. Okay. Now, what you have functionally capable, you can do everything as the person above could do, but now you can breathe partially without a ventilator or fully without a ventilator, and you may be able to use a power chair. And then the muscles like the biceps, the deltoids, all the scapular muscles start kicking in at the C5 one. So just go across the list and you'll see that's how I want y'all to really get to see things in the how really people are in the real world. I mean, like, yeah, I told y'all different types of spinal cord injuries, but really what I want you to know is a C5, what should a C5 spinal cord injury be able to do? Well, if you look here, you should be able to remember back from semester 2 that all of those muscles are innervated by C5, some of them C6. And then those are the movements. And then if you look at the functional capabilities, I'll be with a C5 injury, I'll have some upper extremity movement. So I can do some bed mobility. I can do some feeding and grooming. I can do my oral hygiene. I can assist with some activation of some switches or computers. I can push a manual wheelchair a few feet, but I will be able to adapt and use adapted keyboards and mice or mouses, whatever it is. And believe it or not, even with a C5 injury, you can drive a car with an adapted car steering wheel, as scary as that sounds, believe it or not. I'll have to show a picture of y'all for that. I'll have to pull a picture of y'all and send you all that. Very scary to think about C5s are out there driving on the freeway, but they are. But they have to pass several driving tests, so they do drive well. And if you look at what they can do some assist with their own dressing, some assist for meal prep. They can assist some with a showering and unlevel surface, the bladder and bowel care. So they can assist with all that stuff, but they do need some help with it all. And then C6 needs some help, but able to do more. And then C7 pretty much can do all self-care. Now these people are going up ramps, so they're doing the hard stuff. And then when you get down to the lumbar region, these people are walking with, or these people are doing gait training. So that's how I want you to read this chart, okay? So read through this chart. I don't want you to memorize it, but keep it on hand and bring it to lab with you this week. And we still have to do, we're going to be focusing on gait training this week, but I am going to throw out to y'all some functional questions about spinal cord injury, because I want y'all to start thinking about myotomes a lot, okay? So we haven't really talked in the program about myotomes much since probably whenever you had Miss King. And did she talk about myotomes in conjunction with manual muscle testing? You remember? Or was it more anatomy?
I think it was more anatomy.
Probably more anatomy, I would think. Yeah. Well, get out your old anatomy books, get out and use the chart that I've got, and use those together, and just start thinking. And just thinking, and if it's not making sense, think of functional things like, okay, if I want my patient to eat by themselves, okay, well, do a eating motion and do it, and then think, okay, well, what are a few muscles I need to be able to do this hand to mouth motion? I need to have deltoids, and I need to have biceps, and I need to have finger flexors and graspers. So think about, okay, well, if I was a C2, could I do that? No. But if I was a C6, could I do that? Yes, I could with a Tennodesis Grasp. And I was a C7, I could do that with no Tennodesis Grasp, or I could do it completely independently. So that's how I want y'all to think of this. Okay. Any major questions? You all look brain dead. I've done my job. Okay. Send me questions over email. Don't wait till lab day. And yeah, so there's lots of stuff coming up in lab. Yeah, this week in lab, we're going to be focusing on gait mostly. So watch the gait videos. Now we are going to, a couple of extra force use things we didn't get to were how to get your patient. We did talk about how to get your patient from supine into prone on elbows, but we didn't go from supine into quadruped. And then we didn't learn how to get a patient to and get them up from the floor in case they fell. So we'll start off with that tomorrow. That'll be quick. And then we'll jump into gait too. Okay. Gait's pretty fun. So gait, it'll be a fun lab. So we'll start that tomorrow. So if you have your gait belt still, if you haven't lost it, please bring your gait belt. I know Miss King and I have not been using gait belts this semester so far, but because where we worked, we didn't use gait belts. But if you went anywhere else and did any of these things we're teaching you without a gait belt, you get fired the first day. So sorry we haven't been using them, but we promise you we will start using them from now on to get you in the habit of it. But if y'all don't have any questions, y'all can go.